Isaac. I'm one of the final year medical students, if you don't know me. So today we're going to be doing gum and HIV. This is one of those specialist topics, especially the HIV side. So I've kind of given you basically a sort of what you need to know in terms of the HIV sort of indicator diseases and what sort of management and recognition you guys are expected to know. And then the gum side of it comes up quite a lot in the exams, and I think that's because it's in the sort of GP section. So we'll cover all those today. So I made this sort of new style last time, and I took your feedback on board. And basically, I've tried to adapt this one to kind of what you guys wanted. The reason, so you guys preferred this new style with the OSCE tips, and I think that's especially pertinent after what you guys have been saying to us with regards to, you're a bit worried about OSCE as seen as you've not done one. So in this presentation, I'm going to go over one of the most high yield OSCE stations. I think it'll definitely come up. I've put in more SBAs. So with regards to the revision material, I've tried to make these little summary slides at the end, but like I said, I think it's just a bit of a waste of everyone's time if I make these revision resources for you when there's already the PassMed textbook and QuesMed textbook, which I've said is the best sort of way for you guys to learn the content. But anyway, so what I'll cover today is STIs. So this will probably come up quite a lot in your GP section of the exam. We had a lot of questions on it, and I've seen it come up in the mocks, and it's on the Moodle quizzes. HIV, so I'm going to do the OSCE station, but we'll go through that later. AIDS-defining illness, we'll go over penile ulcers and syphilis. I'm going to talk about contraception in my gynecology talk, and hepatitis is a bit of a fourth year topic. So that's what I'm going to go over today. We've gone over this to death, so I'll just move on. All right, so we'll start with STIs. So we've got a 21-year-old female presents to her GP with abnormal vaginal discharge. So there are sort of 5 conditions that can alter vaginal discharge, and they all present quite similarly. So do you know what these 5 conditions might be? If you want to put them in the VVox chat. Yeah, candidonitis. Yeah, bacterial vaginosis. Good. Trich. Yeah. Yeah. Chlamydia, gonorrhea. Yeah, so you guys have got it. So these are the sort of 5 most important conditions with regards to this subject that you guys need to know about, and we're going to go through all those now. So keeping those in mind, are there any sort of key questions that you want to ask this patient to try and help you narrow your differential? Yeah, colour, good. Consistency, yeah, nice. Smell, itch. Good. Blood as well. Sexually active, yeah, nice. Good sort of questions to be asking. Soreness, fever, good. So the sort of main ones that I thought of were colour of discharge, smell of discharge, whether they're itchy, whether there's ulcers, any urinary changes as well. STIs, urinary tract infections could present this way as well. Sexual history, which you guys have mentioned, so protection, are they sexually active? Nice. So move on to the first SBA. So if Bolin could start a poll, cool. All right, so I'll let you guys crack on with it. All right, cool. So the sort of way to do these questions are learn these sort of buzzwords, basically. So white, curdy discharge, sour milk odor, associated with antibiotics use. You're thinking about thrush. Bacterial vaginosis has the fishy odor, it's grey in colour. Chlamydia and gonorrhea are the ones that are a bit more tricky because they can be asymptomatic, but normally you'd get urethral discharge and dysuria in men, and you can get instrumental bleeding, instrumental bleeding with chlamydia, and gonorrhea sort of present the same. And then trichomonas has this profuse, frothy, yellowy vaginal discharge and is associated with non-gonococcal urethritis in men, but we'll go over that later. So our patient reports that her vaginal discharge has become watery and has a strong fishy odor. Colour has changed, it's become grey. It's not associated with any itchiness or redness. No pain on urination. has a regular long-term partner but doesn't use any protection, and her partner's reported no symptoms. So I've just seen, is there any way of differentiating between chlamydia and gonorrhea in questions? So it would be the sort of test that they do, which we're going to go through later. And remember that chlamydia is far more common. It's the most common STI. But yeah, you guys have answered this right. So BV is the most likely diagnosis in this patient. Do you know what the diagnostic criteria are for this condition? AMSEL, yeah, nice. So what sort of pH? Yep. Anything else? Whiff test, yeah, nice. Clue cells, good. Yeah, you guys have got it. So the AMSEL criteria, so vaginal pH above 4.5, this grade discharge, whiff test positive, and clue cells present on wet mouth. Great, nice stuff. Okay, so move on to the next SBA. Yeah, brilliant. So, as I just mentioned earlier, chlamydia is the most common STI in the UK, and this is how you diagnose it. So, swab and NAT test. Urinalysis is used more in sort of a UTI picture. Whiff test we already spoke about is BV. Direct microscopy and culture is used for trichomonas and gonorrhea, and clinical diagnosis is your oral, your thrush and candida infections. So the reason why I'm asking these sort of questions is because these are things that you should know, and they've come up before in our exams. So what's the best treatment for our patient here? Metronidazole, yeah. Okay, so metronidazole or clindamycin, they might throw in a pregnant lady who gets BV, and then you still use metronidazole. You don't need contact tracing for this STI, but are there any other STIs where you can use, where you need contact tracing? Gonorrhea, yeah. Chlamydia, yeah, basically those two. Chlamydia and gonorrhea. Okay, yeah, fine. There's a bit better on the slide there, but nice. Yeah, so when you sort of see these patients in GP setting, you need to do contact tracing, and contacts of confirmed chlamydia cases should be offered treatment prior to results or investigations being known. So you do the treat then test, basically. Just a little sort of thing to be aware of. Okay, so we'll move on. Yeah, brilliant. You guys know all these. Oops, sorry. So yeah, these sort of questions are very commonplace in our exams. I think this one might have even come up. So yeah, just make sure you've got this known. Direct microscopy reveals gram-negative diplococci. So we're thinking gonorrhea. So first line treatment is ceftriaxone. Doxycycline is first line treatment for chlamydia. Azithromycin given as a single dose for chlamydia if there are issues with compliance. You can also give KEF to cover possible gonorrhea infection, that should say, sorry. Metronidazole, we've spoken about, treatment for BV and also for trichomonas, and clotrimazole is for candida. I wouldn't worry too much about the sort of second line things and if there are issues, but definitely know your first line management. So doxy for chlamydia, kef for gonorrhea, metronidazole for BV, and trichomonas, and clotrimazole for candida. These questions come up very regularly. There'll definitely be one. Okay, so next question. I wouldn't get too bogged down on the sort of second line things. Yeah, you guys are smashing this. Yeah, perfect. So I guess B potentially might be the second line treatment for gonorrhea. But like I said, I also wouldn't worry too much about the doses either. I just put these in here for completeness and just sort of, so you guys are sort of aware. But just knowing the drug treatments for each condition. And what I was trying to highlight here is direct microscopy reveals flagellated protozoa. So this is your trichomonas. Just make sure you've got these buzzwords nailed, which you guys seem to be smashing anyway. These questions do come up. I want to reiterate that. They're easy marks. And then last one, I think. Yeah, you guys know your stuff. So this is non-gonococcal urethritis, basically. So this just basically means there's urethritis, but there's been no gonococcal bacteria identified on the initial swab. So this is basically like a typical case would be a male who's presented to a clinic. He's got some urethral discharge and dysuria. Swabs taken, microscopy performed, and you can see neutrophils, but there's no gram-negative diplococci, so there's no evidence of gonorrhea. This patient's obviously got an STI and requires treatment. So instead of waiting for a test result to come back for like chlamydia, you assume that it is chlamydia basically because it's the most common STI there is. So you treat accordingly. So there you got your doxycycline. And then these are like the microscopy. So these are the things you can see. So does anyone know what this is showing? Does anyone? Okay, so this is your no. So this okay, clue cell no. Yeah, left is gram-negative diplococci, and then on the right, they're meant to be the flagellum on the protozoa. So that's your trichomonas. I've just put those in there for completeness. If you were to get one, it would definitely more so be something like the gram-negative. But like I said, if they did give that in the SBA with a picture, you'd also get a history. And it would sort of be easier to figure out. But once you've seen them, you've seen them once before, so you'll recognize them again, basically. Why were there no organisms on the chlamydia question? So it's just, where were we? This one. So non-gonococcal urethritis. Because I'm not actually sure why they don't show anything on microscopy, but the neutrophils there are showing that there's an infection. Basically, you just don't see the classic yeah, intracellular welling. Nice, you guys are way smarter than me. But either way, I learned the buzzwords, and I knew that was non-gonococcal urethritis, and you treated it with doxycycline. So that's a sort of whistle-stop tour of these STIs, and I guarantee you everything that I've just told you would be enough to get you through any SBAs that you might see on this. I've given you a summary slide of all the buzzwords and the treatments and the management and the investigations. You can look at that in your own time, but I guarantee those questions will come up and they'll be similar sort of level. Don't neglect it. Make sure you guys have smashed all the questions. They're easy marks. So now we'll focus on the main sort of side of this, which is HIV. So what I'm going to do an OSCE station that will almost definitely come up, and the rest will just be SBAs to sort of test key points. So HIV target testing is something that John Cartledge loves. There are 3 things that are guaranteed in life: death, taxes, and John Cartledge putting this OSCE station in. So we'll go through it and we'll sort of treat it like a bit of an OSCE station. So does anyone know the structure that you're going to use for this station? I'm pretty sure John Cartledge has told you it before. Yeah, Reba, well in. So this is probably one of the most important things that you guys should learn for your OSCE. Does anyone know what it stands for? Yeah, reason first. Reason for getting tested. Exposure, yeah, that's one of the E's. Explain. Benefits of having the test, yeah. Ever had a test before? And then the A is agreement. So this is the sort of structure that you guys want to go through. So reason for testing. Have you ever had a test before? And then you explore their exposure. Then you talk about the benefits and the basics of the test. And then you come to an agreement with the patient. So what I'm going to do is I'm going to go through each of these and sort of give you a structure that you guys can use, and we'll talk through it through the VBox chat. So the reason for testing, so I've got the 4 R's. Can anyone think of some reasons that you might need to get a test? Routine, yeah, nice. Any more? 4 R's, so one of them you've got. Risk factors, yeah, nice. Risk exposure, yeah, good. Pregnancy, I don't think of that, but yeah, that is correct. So risky behavior, yeah, anal sex. Request a test, yeah. And then the last one that I've got is red flag diagnoses. So routine, risky behavior, red flag diagnosis. I'm going to talk about those later because they're also very important in their own right. But that would be things like a patient presenting with Kaposi sarcoma, for example. That's sort of a red flag HIV indicator condition, but we're going to talk about that in more detail. And then lastly, request. So we've figured out why they need the reason for having the test. So what do you need to ask about? Ever had one before? Patient. Okay, so the result, when, yeah, why, yeah, perfect. So have you ever been tested for HIV before? When was your last test? Why did you get a test, and what was the result? So these are sort of important questions that I think you guys should be asking. And I'm sure we never got to do this station, but I've heard it comes up every year. So I'm sorry that I can't give you better sort of guidance on it. But I imagine they'll give you some sort of spiel that you guys can like work around. I do think we did practice this actually in one of like the OSCE days in Mod B. So yeah, it's just so important. So exposure. So this is where you're asking about what things they've been up to that could potentially increase their risk. So these are the sort of personal questions that you might want to ask. So do you guys have any sort of idea what things you might want to ask about this? Yeah, so IVDU. We can talk about the empathy side to it at the end. I've got stuff like that. Yeah, paying for sex, receptive, sex with endemic person, nice. Blood transfusions, good stuff. Ever paid for sex, tattoos, yeah, good. Yeah, condom use, contraception, unprotected. This is going to be like the bulk of the station. Yeah, so men, sex with men, any other bloodborne viruses, nice. Ethnic background, good. Okay, so these are the sort of things and the structure that I've got in place. So sort of ask about their sexual history. So are they sexually active, men, women, or both? What's the time scale? Like, when was your last sexual partner? The countries of origin. Do you know the status of your partners is a good question as well. How many partners have you had? And then you can ask about the sort of type of sex. So is it vaginal, anal, or oral, insertive or receptive? Do you use protection? Exchange of money is another good one. I've not mentioned it here, but I just remember to like use of drugs when having sex, traveling abroad, and then like your IVDU risk factors and blood transfusions. Excuse me. So you guys are quite hot on this. So this will be the sort of the bulk of the station, I imagine. And then, so from what they tell you, I think I do remember doing this now in the year 5 mod B sort of end of assessment or whatever. And I remember the guy told us he'd been having unprotected sex and all the rest of it. And then you sort of need to make a judgment based on what they've said as to whether or not they need a test. But if they request it, then you give it to them anyway. But this sort of gives you an idea as to what the result might be. So most likely they'll have some key or obvious reason, meaning that they'll definitely need to take a test. So like things that you could say, so given what you have told me about X and Y, there may be a chance that you could have caught HIV as you've got an increased risk due to your increased exposure. So, and then you need to sort of explain that, given what you've told me, we would recommend that anyone in your situation should have a HIV test. And you guys can make a judgment on sort of how to phrase that and how to sort of angle that in the OSCE station should it come up. And then we want to talk about the benefits of having the test today. So what sort of things might you want to say in this section? Any ideas? So I've just seen someone's made an excellent point about PEP and PrEP and all the rest of it. I do think I remember asking Jonathan Cartledge about this, and I think you guys need to be aware of it, but you would never be asked to prescribe it or make a decision about it. So I'd say no with regards to the PEP and PrEP stuff. Just know what it is my sort of main advice for that. So same life expectancy, stop transmission. It's an incurable disease. Yeah, it's important that you mention that. HIV is not AIDS. Yeah, good. Can treat and have a normal life expectancy. So these are the sort of U equals U as well. Yeah, that's brilliant. Yeah, so that's something you can mention. Basics of the test. Okay, so I'll go through that as well. Benefits of having the test. HIV is a treatable condition and it can be well managed with medications. It's not curable, but you can have a normal life expectancy, and you want to prevent the spread of onwards transmission. And then the sort of basics of the test. So I remember asking John Cartledge about this as well, and you don't really need to know the ins and outs of the test and how they work. It's sort of very basic knowledge. But basically, you have a point of care test, which is the finger prick test. You'll have that done. They'll have that done today, and they're looking for antibody. And there's an antibody test to show the body response to HIV. So they're sort of very accurate, and it'll tell us whether you had it as of 1 month ago. And then you'll need to repeat this because of a 4-week window period. So they sort of have the test 4 weeks after exposure and 3 months after, just to sort of be safe. And then if any of these antibody tests are positive, you'll have to have a blood test to confirm the diagnosis. I get it's a bit confusing. So the antibodies to HIV may not be present sort of straight away. So testing for HIV in asymptomatic patients should be done at least 4 weeks after possible exposure, even if they've had a negative initial result when testing for HIV prior to that. So you need to do one at least 4 weeks after, and then they offer a repeat test at 12 weeks after just to be safe. I think that's basically sort of all you need to know. That's the sort of knowledge that I had as well. The HIV antibody test, it's the most common and accurate test. That's like the fingerprint test. Most people sort of develop the antibodies to HIV around 4 to 6 weeks. And then by 3 months, you sort of expect that 99% of the patients would have done. So that's why you sort of have that repeat at 3 months as well, just to be sure. But that's sort of like the knowledge that you guys should need to know, basically. I wouldn't sort of get too bogged down any more than that. And then you get to an agreement stage. So the patient should, give consent to having this test. So they need to agree with you. So you sort of want to counsel them a bit. So this is where your sort of empathy side can come into it. So you want to do agreement to the test, yes or no. If no, why? You should explore this. Are they afraid of the diagnosis? There might be a lot of stigma. They might come from a background or a family that might have a very negative response to it. You should sort of ask them, how they'd feel or cope if they found out they were positive. Let them know that there's support let them know that there's support available. And whilst you're doing this sort of thing, you want to do an STI screen as well and offer leaflets, give them more information. I think that's basically the crux of the station. We'll talk about seroconversion really quickly. I see there's a lot of questions. We'll talk about, if there's any confusion, we'll go over it at the end if it's not been cleared up in the chat. So just keep that in mind. But we'll just crack on for now. So patients may present with a seroconversion. So seroconversion is the period during which the body starts producing HIV antibodies. And as I mentioned, this sort of usually occurs a few weeks after initially contracting the virus. And then, once you're infected with HIV, I'm sure you know how it works. The virus takes hold of the body's cells and sort of hijacks them and produces more virions. And then your body sort of makes an immune response to this, and you can become symptomatic during this period. And this is known as seroconversion. So how might these patients present? Yeah, maculopapular rash, nice. Lymphadenopathy, fever, diarrhea, good. It's sort of like flu-like symptoms, basically. It can be quite non-specific, but basically these are sort of symptoms that patients might present with. So as we mentioned, flu-like, sore throat, lymphadenopathy, malaise, myalgia, diarrhea, rash, mouth ulcers. So this is something that a patient might present with in this sort of OSCE station. Cool. So moving on from the OSCE station side of it, these HIV test indicators and AIDS-defining illnesses. So these definitely come up. You might have seen them before. I think John Cartledge give you some practice ones in those TBLs. I've seen these at least twice. I think it came up in our finals as well as our 5th year exam. So what I'm going to do is I'm going to do some of those questions to practice. It's basically just rote learning the list, which I've put at the end, but it's just good to get some practice in. And I've thrown in a few rogue ones just to sort of make you aware of them. And then we'll focus on the sort of specific questions on certain AIDS-defining illnesses and how they present and how they're treated. So I'll give you a bit of time for these questions because they can be quite tough and they require a lot of like thinking and narrowing down. Okay, interesting. So the actual correct answer to this is 1 and 2. So these questions are tough, and I've made them hard on purpose, but I've literally just copied them from the list that is sort of given online. So a 33-year-old man presenting with esophageal candidiasis. So this is an AIDS-defining illness. Strongly recommend testing. 70-year-old man with seborrheic dermatitis. So this condition is actually associated with undiagnosed HIV. So it's strongly recommended testing for this. 25-year-old woman with pneumonia. So it has to be a recurrent pneumonia. So 2 or more in 12 months. I know that's question 3 is a bit vague. The statement 3 is a bit vague, sorry. But it wouldn't, you know, a 25-year-old woman with pneumonia, just a normal pneumonia, you wouldn't be testing necessarily for HIV. If it was TB, then that's a different story. Or if it mentioned she'd had 2 or more infections, then you'd strongly recommend having a test. 30-year-old woman with Hodgkin's lymphoma, so it's non-Hodgkin's lymphoma, that is an AIDS-defining illness. 63-year-old man with unexplained thrombocytopenia for 2 weeks, so it has to be longer than 4 weeks. So these are just taken straight from the list. I've got it at the end. I appreciate a lot of you sort of went for the other options, but I'll show you at the end where I've got these from. I think the ones that you'll get will be a lot more straightforward. I've made them a bit harder on purpose just for practice sake. So we'll do some more. I've seen Dr. Cartledge said today you should test if anyone with pneumonia. If that's what Dr. Cartledge says, then by all means, please listen to him. I'm sort of just going off these are the testing criteria. Whatever he says goes. I'm sorry if that's caused some confusion. Sebderm is very common dandruff. Okay, perhaps maybe I should have made that a bit more explicit, that it's been quite widespread and it's all over the face, but it definitely is on the list. Okay, sorry, I should have made that a bit more clear that it was severe. I was trying to just test that point, basically. Okay, E. Yeah, nice, well done. So you guys smashed this one. Sorry, I may have made it a bit confusing for the first one. Yeah, so 1, Kaposia sarcoma, AIDS defining. You need to definitely test there. Viral gastroenteritis doesn't warrant testing. Cervical dysplasia, yeah, that is associated with undiagnosed HIV. I'm sure you're all aware from like gynae that it can be associated. So yeah, 56-year-old man with 3-week history of herpes simplex ulcers has to be 4 weeks. And as I mentioned, TB pneumonia is AIDS defining, and you definitely want to test that. Okay, so we've got one more. Okay, so the correct answer to this one is D. Have I put Y? Okay, fine. So anyone with an STI should get offered a HIV test, so that's why 1 is correct. 57-year-old woman with new diagnosis of toxoplasmosis. So this is another age-defining illness. Fever of unknown origin also warrants a HIV test. And also a new diagnosis of primary lung cancer. These are all on the list that is on the next slide. And 34-year-old woman with bacterial meningitis. So it's actually viral meningitis for some reason, but I've just taken these off this list here. So I'm sorry if I've made some confusion there with the pneumonia thing, but this is where I got the information from for these questions, and this is what I sort of learned in my 5th year. Whatever John Cartledge says goes. I'm sure he's probably given a lecture on this and a talk on what he wants you guys to know. But I just wanted to reiterate the fact that these questions do come up in that exact same format, and you might get 1 or 2 on it. So just make sure that you go over this, learn these guidelines, and learn whatever John Cartledge says. Yeah, I hate the rote learning sort of aspect of this. And I made them tough for the sake of being tough, but learn these, especially the HIV indicator ones, the AIDS-defining illnesses. They will definitely come up. Calling JC John is stressing me out. Okay, fine. But anyway, I personally would learn the whole thing, but emphasis on the yellow box because they're the AIDS-defining illnesses. If John Cartledge has got more information on this, use his slides and just take what he says as gospel truth. Okay, so another SBA. Yeah, easy peasy. Just make sure you know this. I think this might have even come up in our exam. Easy question. Yeah, just a fact to be aware of. All right, SBA 8. Yeah, okay, nice. So interesting, people went for D as well. So this is a CNS lymphoma. So you need to treat with steroids and chemotherapy. Sulfadiazine and I can't even say those. Pyrimethamine, treatment for toxoplasma. So this is why I don't like these questions, but they definitely do come up. So you would never treat toxoplasma and give steroids at the same time. So that's why C is wrong. Also, that's why D is wrong. You never give steroids if you're treating toxoplasma. I remember John Cartledge saying that. So that's sort of a fact there. I've tried to reiterate to you guys. I think it's to do with like you're going to suppress the immune system even more, so it's just not helpful. And then also you want to see if the treatment for toxoplasma is working. So steroids will reduce edema and inflammation, but then you don't know whether or not it's because of the steroids or you're treating toxoplasma, if that makes sense. And then plasma exchange can help treat PML, niche, whatever. Don't think you'll get asked about that. But this came up, and I think it came up twice. So you need to be able to tell the difference between toxoplasma and CNS lymphoma on CT. And I remember sitting in the exam being like, shit, which one is it? So I think it's good to practice. So let's see whether it's toxo or lymphoma. So what's this one? Yeah, lymphoma, nice. And we'll sort of talk about why afterwards. What about this one? Yeah, this one's toxo, nice. What about this one? I can't tell if people are actually adding. Yeah, toxo, nice, nice. Okay, what about this one? I'm loving the L's and the T's. Perfect. Yeah, so you guys know, you've seen a few of these now, you can definitely recognize. So the way to sort of remember it is the fact that toxoplasmosis, there'll be more than one basically normally, and also with a CNS lymphoma, you're more likely to get a big what do you call it? That mass effect. So structures will be pushed out of the way. Like if we look at the first one, like this one, oh bloody hell, where is it? And this one, the ventricles have been pushed, so that's also quite indicative. And I can appreciate that sometimes they look quite similar with this ring around the outside, but it's just different type of imaging, I guess. But you'll definitely get presented with a picture of one of these on your SBA, because it definitely came up for us. And the frustrating thing is that they present very similarly. So you sort of get, headache, confusion, potentially seizures, or like local neurology. So that's why they're quite tough to sort of delineate clinically. But on imaging, you can sort of see the difference. So it's just sort of something to be aware of. It does come up, and know the treatment as well, which I've given you on those SBAs. So I mentioned why steroids are not used in toxo at this earlier, but I'll reiterate again. I think John Cartlidge told me, because if you suspect toxoplasma, you want to start them on treatment for toxoplasma, right? And yeah, steroids are immunosuppressed, but steroids will inherently reduce inflammation, make the lesions potentially smaller, and you don't know whether or not the toxoplasma treatment's actually working, or whether it's the steroid that's having the effect, if that makes sense. That is why. Okay, so we've got the two side by side there. I think they'll be quite obvious in the exam, despite the fact that I remember having difficulty with it. But just definitely go over it and go over the treatments. Okay, we'll move on to the next question. Do we give steroids in PCP? Interesting you asked that. We'll find out. So you fell in the trap that I set, and UCL also set this trap for us. So basically, they gave a stem where the patient had HIV, but they had sort of no reason to make you think that they were immunosuppressed, they weren't compliant with medications, etc., etc. So it was kind of like the HIV was being well treated. So PCP would only sort of become an issue when the CD4 count is very low. So despite the fact that they've got HIV and their symptoms are well controlled, what was I going with that? Despite the fact that they've got HIV and it's well controlled, it's potentially unlikely that they might get PCP. And Streptococcus pneumonia is the most common cause of pneumonia. And this question came up for us, so it potentially could come up for you guys again. I just wanted to highlight that. Look out for the sort of buzzwords, but they might mention normal CD4 count, low CD4 count, it has poor compliance, etc. Don't get too beat up about that. but now you've seen it. Okay, so move on to the next question. So just to sort of, oh, well, we'll crack on with this one. I'll go back. Okay, nice. So majority of you got this right. Obviously, you all know that cotrimoxazole is the treatment for PCP, and I've made it barn door obvious with the SAPs drop in, all the rest of it. But on here it says his ABG shows hypoxia, and if you've got PCP and you're hypoxic, you give steroids as well. Just sort of wanted to raise your awareness to that, because I actually didn't know that until I was writing these SPAs. I feel like it'd be tough to give you that. John Cartledge sort of, I remember him saying, just know the basic management. So PCP, cotrimoxazole, you know how it presents. Oh, he spoke about it today. Well, you obviously know more than me then. IV or PO, I have no idea, if I'm being completely honest. I'd imagine PO. IV steroid is quite a big deal. But going back to the previous question, why there's no mention of CD4 count. So I sort of alluded to the fact that this patient might be well treated because he's well known to the hospital services. So that sort of was implying that they're regularly attending their appointments and they're sort of compliant with their medication. A lot of people are getting a bit bogged down on this question. I just made it hard for the sake of it. Cotrimoxazole is basically all you need to know for PCP. This was just a little extra point. You'd see it on ABG, the hypoxia, not on the SATs. Steroids meant to help with the inflammation. Yeah, nice. You guys sort of know more than I do if you just had a lecture on this. But cotrimoxazole, definitely know that. Treatment for PCP. All right, so we'll do a few quick fire pictures that may come up and SBA points that are important for you guys. So does anyone know what this is showing? Yeah, Cryptococcus India ink, brilliant. So you've done my next question. India ink is the name of the stain. And what would you classically see on an LP with this? Yeah, high opening pressure. Nice. Perfect. So that is basically all I learned for Cryptococcus. If you want to learn more, go ahead. But I did perfectly fine on my fifth year exams with that knowledge. Same again. So what is this showing? Pizza pie. Nice. CMV retinitis, basically. Yeah, well done. How might this patient present? Like, how would this affect blurred vision? Yeah, brilliant. Well in. So how do we treat this? You did actually have this in yesterday, Bolin, and I remember because I was thinking, oh crap, they've already going to have seen it.
No,
Nice. Cool. Very good. Oh, is that it? Oh. Okay. So sort of HIV summary. So I'd say practice REBA, learn who you offer tests to, know the management of toxo, CNS lymphoma, and PCP. So I've basically told you all that. Be aware of other aids defined. I thought I had another slide. I swear I had. Is this the right presentation? Anyway, we'll crack on, and if there's issues, we can address it. I swear there was some Kaposi sarcoma on there. Maybe I deleted it by accident. Anyway, yeah, Kaposi sarcoma as well. I was meant to have a picture of that, but you guys know what that looks like. Cool. Wait, I swear I meant to have more. Sorry, just bear with me one sec. Interesting. All right. Treatment for Kaposi sarcoma is just treat the HIV, basically, I think. Anyway, we'll crack on, and if there's stuff missing, I'll have a look and we can go over it. So we'll move on to penile ulcers. Would anyone like a little break while I have a look for this presentation, why it's messed up?
Yeah, let's have a quick one because they're getting a bit razzed on it. Take 2 minutes, I think.
All right. Why is that?
There's a lot of pollution in the VBox chat.
Yeah, have a little 5-minute breather while I just try and figure out why this is messed up. Which one did I send to you, Bolin?
You haven't sent them all.
As in, which one did I upload?
This one. It says...
What's it called? Sorry.
Let me check. You called it Gum and HIV Final, which sounds
pretty set in stone, doesn't it? Yeah, I'm a bit annoyed. Just bear with us, guys. And my laptop's decided to be monumentally slow right now. Modified 16th of June. I just hope this is finished. Anyway, we'll start again at 6. There's not much left. This is quite a quick bit, and then syphilis. Isaac, your curls. Oh my God. Okay, I think I just basically didn't include it on this one, and I had it on the other side and another one, but it's fine. Okay, fine. Yeah, sorry, I forgot to include Kaposi sarcoma, but yeah, you guys, I'd recommend just knowing what that looks like. It could come up, and know it's an AIDS-defining illness, basically. Right, is everyone ready to start again? We can crack on. Sorry about that little interruption. Okay. The ones on that list, so things like esophageal candida, Kaposi sarcoma, toxoplasma, CNS lymphoma, they're on that list that I included earlier. Anyway, we'll crack on. Should be about half an hour left. So penile ulcers. So a 24-year-old man presents to his GP complaining of an ulcer on his penis. What questions would you want to ask to help narrow your differentials? Think of like some buzzwords for different types. Painful, yeah. Yeah, number, good. Lymphadenopathy, nice. Discharge, lymph nodes. Yeah, that's basically it, really. But some more sort of, so yeah, one or multiple, painful or painless, sexual history, lumps in the groin, are they painful or painless? Are they itchy? Any systemic features and any topical travel? So what differentials can you think of for penile ulcers? LGV, nice. Syphilis, good. Yeah, Bantitis, well in, yeah, nice. Herpes, Behcet's, nice, well in, room, we'd love to see that. So I've got syphilis, LVG, herpes, chancroid, Behcet's, Ballantitis, nice. So multiple painful penile ulcers are most commonly caused by herpes. Other sorts of infection, so you've got Ballantitis, Candida, Trichomonas, and then chancroid, not to be confused with chancre, which is syphilis, is caused by Haemophilus ducreyi, I think that's how you say it. And as I mentioned, it's like other dermatological or room conditions like Behcet's, things like pubic lice or scabies. And then a single penile ulcer, most commonly caused by primary syphilis. And these are sort of painless in nature, with an indurated base. So they're sort of the main things to be aware about. So how do we distinguish between each type? So I've sort of made this little flow diagram of how I sort of learnt it. So you start by thinking, are they painful? Yes or no? No. Do they have painful inguinal lymph nodes? Yes or no? If yes, then it's LGV. If no, then you're thinking syphilis. Is it painful? Are there multiple ulcers? Yes, you're thinking herpes simplex. No, but they have painful inguinal lymph nodes and potentially a history of tropical travel. You're thinking of chancroid. So that's basically sort of how I'd sort of go about delineating between them in an SBA. I found this quite useful. And that's basically all I knew about them, to be honest. I'm just sharing with you guys what I learned for my exams. So we'll crack on with our patient. So he presents with his GP, blah, blah. History of presenting complaint. He reports multiple painful ulcers. They're itchy. He's also had a fever and reports numerous unprotected sexual encounters. So what's the most likely diagnosis here? We'll go about syphilis later. Herpes, yeah, well in, most common. Herpes simplex virus, nice. So what investigations would you want to do for this patient to diagnose? It's NAT, yeah. Nucleic acid amplification test. How do you manage this patient? Clinical diagnosis, yeah. It is clinical, but you can use a NAT test. Yeah, acyclovir, nice. So primary infection, you give oral acyclovir. And then the summary for that is basically this. I'm not going to, mess you around. That's basically all I learned. I don't think it even came up, to be honest. I don't remember having to use this sort of thought process in the exams. But that's just a sort of, I just make sure you know that summary that I've given you there. And I think in the SBA, they'd most likely ask you what's the most likely diagnosis. I actually don't know how you treat chancroid, but you can look that up. I don't think you'd be asked to do that in an SBA anyway. So we'll move on to syphilis. This definitely does come up. So a 27-year-old man presents to his GP with a painless ulcer on his penis. So this is basically primary syphilis. This sort of happens 90 to 90 days after exposure. Crap. So basically, how does primary syphilis present? So we've got the chancre, which is the non-painless ulcer, not to be confused with chancroid, which is caused by Haemophilus ducreyi, the painful, more necrotic genital lesion that has painful lymphadenopathy. So how does secondary syphilis present? What features can you think of that? Yeah, rash, nice. Snail track ulcers, nice. Yeah, good stuff. So you guys know how to recognize this. This could potentially occur 6 to 10 weeks after primary infection. You get systemic symptoms, so like fever, lymphadenopathy. You get the rash, snail track ulcers, which someone mentioned, and then condylomartulata. That's a mouthful. But basically, this is what the rash might look like, and these are the snail track ulcers. Unsure whether or not they'd show you something like this, but just something to be aware of. You've seen it now. Okay, so what sort of things present in tertiary syphilis? Gummer, nice, yeah. TB, yeah, dorsalis, yeah, gummer. Ataxia, good. Okay, nice. So these sort of things are rare now due to penicillin and the treatments. But as you've mentioned, the features include things like inflammation of the aorta, so you can get aortic aneurysms, tabes dorsalis, ocular manifestations. So I'm sure from your OPVAL lectures, you know about Argyll-Robertson pupil, and you can get like these gummers on the skin and various other places. If you suspect tertiary syphilis, you want to confirm it with CSF examination, and you want to make sure there's no CNS involvement. Way above our remit. I have no idea what CSF would show. But tabes dorsalis, if you can't remember, is basically like dorsal column lesions. So you lose loss of vibration and proprioception. And I hated learning these stupid OPVAL things. But Argyll-Robertson pupil, it's the one where it's like accommodation reflex present, pupillary reflex absent. Go over that in OPVAL if you feel like you need to. It has like smaller. It's the one where it's like there's no response to light, but they accommodate or something, right? I can't actually remember off the top of my head. You guys will know more than me. I hated ophthalmology. Anyway, SBA 11. We're going to go over that in a bit, the Yarish-Herxheimer reaction. I did not learn any incubation periods in different STIs. Perisic goal. Yeah, no, it's just one of those things you've got to learn. I do think this came up. I seem to remember. Yeah, just learn that is the treatment. Okay, so this is what we were talking about earlier. Someone's ruined it, but crack on with this question. Yeah, so you guys recognized this one. So this is the Herxheimer reaction. Basically, once you give treatment for syphilis, you just get this sort of reaction to it. And it's got fever, rash, rigors, tachycardia. I think it's to do with the fact that once the bacteria getting destroyed, they secrete like all their toxins and stuff, and it just causes a big inflammatory response. It doesn't always happen, but you have to warn patients about this. And basically, it's supportive management. You can admit them if they're like quite unwell or very anxious, but just recognize that it's not anaphylaxis. You'd get more of like a wheeze and swelling and stuff like that in anaphylaxis. Also, I think the time frame would be a bit later as well. Okay, so this stuff is horrible, and I imagine there's going to be lots of questions. I've tried to make it as simple as possible, and I've got plenty of SBAs to sort of test it. I'm no expert on this topic, but we'll try and get through it. So syphilis serology and investigations. So it's Treponema pallidum is the organism. So they usually base it on the diagnosis is clinical, and they look at serology, and basically they split the test into two types. So there's these cardiolipin tests. So syphilis infection leads to the production of non-specific antibodies that react to cardiolipin. So they're not specific though to syphilis, basically. So these are the things like your VDRL and your RPR. Other things these become negative after treatment, basically. Whereas the treponema specific antibody tests, they remain positive after treatment. And these include TPHA. I think there's another one as well, which I might have mentioned. Okay, nice. So these are the type of tests that you can have. And I've sort of mentioned that the cardiolipin tests become negative, and the treponemal tests remain positive after treatment. So I've given you an example there. So VDRL will become negative after treatment, and TPHA would remain positive. There are a few, and they do use all of them. I think the main ones to know. Oh dear, what's going off? Cool. Ed, help me. Sorry about that, guys. Just bear with me one sec. We'll just skip back through.
Hang on, I can do it faster rather than skipping through all the stuff.
Oh, go on then.
What slide were we on?
I actually can't remember. We were on like syphilis serology.
Do you want to take control again?
Oh, wait a sec. Let me sync to the presenter. Take back to. Where were we? Right. So I've mentioned. Okay. Yeah. So the other one is the EIA, or the enzyme immunoassay test. So this blood test checks for syphilis antibodies. And if you have a positive EIA test, it should be confirmed with a VDRL or a RPR test, because the EIA detects an acute IgM antibody. I wouldn't get too bogged down on what these tests do and like how they work. Just know what I've learned, what I've told you there. The cardiolipin ones, positive in the acute infection, will go negative when you treat. Specific antibody tests will remain positive after treatment. We'll practice this with some questions, but that's all you need to know. And just make sure you're aware of the different types. So let's say, for example, you have a positive EIA, positive TPPA, and a positive RPRR. That's likely syphilis, right? Because you've got the positive ones that are sensitive to syphilis, and you've got the one that's positive in active infection, right? Positive EIA, negative TPPA, and negative RPR is likely a false positive in an EIA. I don't think you'd get that in an exam question, but it's just there to sort of reiterate the fact that, as I mentioned, positive EIA, an EIA can be positive for other reasons. Basically, it has a false positive rate, but you need to confirm it with a TPPA, for example, and a RPR. Positive EIA, positive TPPA, and a negative RPR would be indicative of someone who's previously treated. And this titer thing that they go on about, so if the RPR is positive and the titer is greater than 1 to 8, and there's no history of treatment, this is diagnostic of syphilis, and the patient should begin treatment. And you need the RPR to decrease 4-fold or decrease below 1.8 for it to be considered adequately treated. Cool. That's all you need to know. That's all I learned anyway. So let's practice some questions and then we can crack on and watch the football. Okay, so the vast majority of you got this right. There's been a 4-fold decrease in the RPR, therefore this treatment has been successful. EIA and TPPA remain positive because they remain positive despite successful treatment, and RPR has gone from 132 to 1 to 8, so it's 4-fold decrease, therefore successful treatment, right? The ratios, basically that just means like how much you need to dilute it before you can't detect the syphilis, whatever they measure. I don't know the cardiolipin thing that it reacts to. But if it's gone from 1 to 32, so it goes down to 1 to 16, that's 2-fold, and then it'll go down to 1 to 8, that's 4-fold basically. I don't really know more than any of that. That's just basically all I know. But that's all you need to know as well. So practice another one. Yeah, you guys did better on this one. So basically, diagnosis, he was EA positive, EIA positive, TPPA positive, and he had RPR of 1 in 8, so he had syphilis. Today, EIA negative, as I've mentioned, is not the most reliable, and you have to confirm it with a TPPA. So his TPPA is still positive, but his RPR has gone worse, basically. So despite the fact that he's been treated, it's not worked. So you want to give them another dose, basically. if that's how easy it sort of is. It's quite simple once you get your head around it. I appreciate it can be quite difficult and quite confusing, but I hope that sort of clears it up. That's just the pure basics of what you need to know. So summary for syphilis: chancre, painless ulcer. Secondary, you get systemic symptoms. Tertiary, you get your weird neuro things. Management is IM. In fact, you can read this. But that basically is all you need to know. I appreciate it's quite a specialist subject and we've gone through quite a lot, but this is honestly all I learned for gum and HIV. And I don't remember it being too tough in the exams. And like I said, it's a very specialist topic, so you don't really need to know too much about it. But this is like the classic exam things. Yes, syphilis treatment can be initiated at any stage of the disease. Endocervical swabs, for what? Why was, so EIA is not the most reliable. I think I've got something mentioned about it. So you can get like false positive and false negative tests with EIA. It's not the most reliable. And also it's looking at IgM. So it's only in the acute phase. So if we look at this geezer, where's it gone? So he's probably had syphilis infection for a long time. So that's potentially why it's negative. It's got IgG response now. Do we need to know CD4 counts? That's monitoring for people doing EPPS. What's EPPS? But yeah, I don't think you need to know CD4 counts or monitoring. That's very specialist. That's what a HIV consultant would do. Oh no, exposure-prone procedures, nah. It can remain positive after infection. It was just a MedSoc Q. What OSCE stuff did you get for gum? We didn't do an OSCE, I'm afraid. Don't worry about dermatoscope. That's so that can't have come up truly. Ed, could you send the feedback form in, please? Because we finished. Sorry, I didn't make that clear, did I? But yeah, fire away any questions. What time is it? All right, I'll stay for a bit.
So the people asking about a dermatoscope, it's almost like a fundoscope. It's a little handheld microscope, and you put it right up to your eye, get right close down to the patient's skin, and it just gives you a really good view of lesions. So what looks like a mole or something, or an ulcer up close, you can see the vasculature, the pigmentation, stuff like that. They're quite easy to use. Like there's no special techers. You literally just like get up close.
There's no way they're asking about that. Like that's like way postgraduate level. What a waste of a station. Plus, like for derm, all you need to know is like if a lesion looks dodgy, it looks like a melanoma, that's good enough.